There was no way I was going back to emergency. I didn't want to be embarrassed again. And besides, a man with the letters MD after his name had told me very clearly, it is not your heart.
Today, I have a very special guest with me. Carolyn Thomas is going to tell her story of misdiagnosis and how her medical experience has become a story that she tells to people throughout the world in hopes that she might save a life and improve the outcomes of heart disease. Carolyn Thomas is a women's heart disease activist and survivor of a misdiagnosed heart attack in 2008. She became the first Canadian ever accepted to attend the annual WomenHeart Science and Leadership Patient Advocacy Training at Mayo Clinic in Rochester, Minnesota. Carolyn's award-winning blog, Heart Sisters, has attracted over 19 million viewers from 190 countries. Her writing about heart disease has been included in the British Medical Journal, for which she also serves as a patient peer reviewer for cardiology papers. Carolyn is also the author of A Woman's Guide to Living with Heart Disease, which was published by Johns Hopkins University Press.
I'll start off with telling my heart attack story, but it starts 2 weeks before I actually was diagnosed with a heart attack. I'm a very early riser. I was out for an early morning walk, and then out of the blue, suddenly, central chest pain, nausea, sweating, and this pain down my left arm. It was so bad that I had to stop walking. I was leaning against a tree. And I remember my first reaction at the time was, this better not be a heart attack, because I do not have time for this today. Because I remember it was the pain down my arm that frightened me. You'd think the chest pain would have frightened me.
Right.
But I thought I remember reading or hearing something about pain down your arm could be a heart attack sign. But after a few minutes, I noticed that the symptoms seemed to be easing up. So I started walking very slowly just to test it out. Eventually, they just went away. And I thought, glad that's over. Whatever that was weird. I didn't think about it, except I had to walk right past the Jubilee Hospital on my way walking home. So I thought, gee, maybe I'll just pop in and I'll get them to check it out. And I worked at the Jubilee Hospital at the time. All of my cardiac tests came back normal, which is quite common in women. And the doctor came out and said, you are in the right demographic for acid reflux. Go home, make an appointment with your family doctor, and you'll get a prescription for some antacids. Goodbye and have a nice life. Well, my first reaction was to be embarrassed. Like I'd made such a big fuss, and they had to do all these tests on me while all the really sick people were waiting in the waiting room behind me. So I felt very embarrassed about this. And I felt even more embarrassed because of a conversation I had with the emergency nurse of the doctor. He is a very good doctor, and he does not like to be questioned. Oh, wow. And I was so shocked that she was talking to me this way, because I'd only asked the doctor one question, and that was, but doctor, what about this pain down my arm? Because I'm not a doctor, but even I know that pain down your arm is not a sign of indigestion. Mm-hmm. And I asked the question, and this is what happened. The nurse, I'm guessing that the doctor had gone back to the back after he left my bedside and talked about the pain in the neck, patient in bed 8 who keeps questioning me. Oh, so the nurse, she was defending her colleague by telling me, the uppity patient, to stop asking questions. Well, because I work with nurses and doctors, I was shocked that any nurse who was supposed to be an advocate for patients, instead, she was putting me in my place. So that was a very powerful moment for me, because when my symptoms returned, which of course they did, because I was having a heart attack, there was no way I was going back to emergency. Because I didn't want to be embarrassed again. And besides, a man with the letters MD after his name had told me very clearly, it is not your heart. And I would just take Tums and Gaviscon. And I did make an appointment with my family doc, but she was away on vacation. But when she came back, I was going to go see her and get my prescription for antacids. In the meantime, I was thinking, holy cow, this acid reflux is brutal. How can people live like this?
Was it pretty constant at this point, or?
No, it would come and go. It would come and sometimes it would last for 20 minutes, and then it would go away for an hour. And every time it went away, I thought, whew, good, I guess it's over. But it wasn't. You'd think that I would have said, this is not making sense to me. But I was too embarrassed to go back to emerge. That was the bottom line. Besides, I had my appointment with my family doc, so I thought it was okay. And besides which, my stereotype of what a heart attack looks like was nothing like what I was experiencing. Because if you look in the media, almost every magazine article about heart attacks will show a man, always a man, clutching his chest in agony.
Yes. And
my stereotype was it was a man, an old man out on the golf course, suddenly clutching his chest and falling down unconscious. And then 911, CPR, paddles, sirens, that to me was a heart attack. So how could I be having a heart attack? Because I walked into emergency for my mother's 80th birthday. And during that whole weekend, by now, my symptoms were back to back, like every day and every night. And I knew I was in trouble, but I knew it was also acid reflux. I knew it wasn't my heart. Mm-hmm. So when I was flying back home from Ottawa, again, why did I get on the plane? I had 2 episodes in the Ottawa airport before I boarded the plane.
Okay.
I had 2 episodes on the plane, on the 5-hour flight. And at no time did I call the flight attendant over.
Right.
Because how embarrassing would that be if they had to turn the plane around for a medical emergency that was just indigestion? Because I knew already, this is not my heart. So shut up and just grin and bear it. I just tried to survive until I got to Vancouver. And in Vancouver, where you take the big plane and then you have to catch the little 20-minute plane to Victoria. So I couldn't walk to my next gate. That's how bad my symptoms were. So I had to flag the little golf cart, the little Air Canada golf cart, and a very nice Air Canada person drove me to my gate, helped me with my carry-on bag onto the plane. And it was only when I got on the little plane that I realized I can't walk to the baggage carousel when we land in 20 minutes. So that's when I called the flight attendant over. Another nice Air Canada man met me with my wheelchair, pushed me to the baggage carousel, where I loaded up. In those days, we could have 2 checked bags. Remember those days? Mm-hmm. So I loaded the bags onto the little trolley and pushed it out to long-term parking where my car had been all weekend. And then I drove myself home. I had already decided. So I was thinking, but I wasn't thinking straight.
Yeah.
Drive blood flow to the brain, I suppose. I knew my nurse friends think this is the funniest part of my heart attack story, if there's such a thing as a funny story. I knew I was going to go back to emergency, but not for my heart. I still knew it's not my heart, but this acid reflux is unbearable and I have to go back to work tomorrow. I can't work like this. I need drugs, serious intravenous drugs, antacid drugs.
Yeah.
So, but I also knew I wasn't going to go. It was a very late flight. So it was about 1:30 or 2 in the morning by the time I was driving myself home. Thank God, because there's no traffic on the Pathway Highway at 2:00, because I'm not sure of the quality of my driving. So I always tell my audiences, I do these presentations called Heart Smart Women. And I always tell my presentation audiences, listen to me, don't do anything that I did. Just now listen to what you should have done. The only good thing I did during that entire 2-week episode was to go to emergency quickly the same day, right away. Mm-hmm. And that might have confused my testing results, actually, because when you're being one of the cardiac tests that you'll get in emergency is a blood test that looks for a cardiac enzyme called troponin. And troponin is almost always associated with heart muscle damage during a heart attack. So it's a pretty specific test. Well, troponin levels tend to rise over time. Well, I was in emergency within probably 20 minutes of my first onset of symptoms. Mm-hmm. So the cardiologist says it's quite possible that for women especially, because our levels tend to be lower than our danger levels of that cardiac enzyme tend to be lower than men's, although there's a cutoff ceiling that says if you're below this level, you probably are not having a heart attack. That's true in men, not true in women. I didn't know any of this. Different emergency doctor this time. And this time I could tell by the looks on the faces, I must have looked like death warmed over, first of all. And I could tell by the look on the staff's faces that something was very wrong. This time they called in a cardiologist. But this time the cardiologist came in, he looked at all my test results. He came and he held my hand. I remember he sat down right next to me. So his nose is very close to mine. And he held my hand with both of his hands, which almost made me cry. I just thought, he was so present and so different than the last doctor that I'd spoken to 2 weeks earlier. And he said, Mrs. Thomas, I can tell by your test results, your T waves, that you have significant heart disease. Oh. And I said, well, how can that be? Because this very hospital sent me home 2 weeks ago with acid reflux. And he explained to me that because women's diagnostic testing for heart disease have all of the diagnostic tests that we use today for the past 4 decades have been developed and researched on men, white, middle-aged men. So they work pretty well in identifying heart disease in men. I didn't have vague, atypical symptoms that we sometimes hear that women have during a heart attack. I had classic Hollywood heart attack symptoms, central chest pain, nausea, sweating, and pain down my arm. So even with those symptoms, I was still sent home.
Did they not give you any guidance on, what to do if the symptoms change, or?
One of the staff said, if they come back, come and see us again. So they did as I was leaving, but now I've already had this encounter with the nurse. So there was no way I was going to come back to these people.
To be humiliated. Yeah.
To be humiliated. Yeah. Mm-hmm. I was already embarrassed. And it turns out that embarrassment is a key issue in women specifically. There's a whole field of research called treatment-seeking delay behavior in women heart attack patients. So I felt better when I heard that news because after I was correctly diagnosed and appropriately treated that day, I went immediately from the ER to the OR. Once I got home, and all my family were furious with me. And because when you tell my story, it sounds like I'm a crazy person. So it turns out treatment-seeking delay behavior is remarkably common in women heart patients.
Wow. Okay. So you were in the ER, finally you were correctly diagnosed, and you said you went directly to the OR. What were they doing in the OR for you?
Well, my first stop was in the cath lab, what's called the cath lab. I had an angioplasty, which is where they put a little balloon through the wrist, thread it up into your heart, where they found a blocked left anterior descending coronary artery. That's one of the biggest coronary arteries in the heart that feeds the heart muscle. And it was blocked, so that was what was causing the pain. So I had a stainless steel stent implanted that day. Okay.
And did that resolve the acute issue?
It did. But it didn't completely. I got home and you're in such a state of overwhelm, and my kids were flying in from, both of them lived out of town, and they both were flying in. And so lots of fuss around my friends, and I wasn't on anyone's radar as, I didn't smoke, and I didn't have, the risk factors that we think about if we ever do think about heart disease. That's the other thing.
And sorry, Carolyn, how old were you when this happened?
I was 58.
58. Okay.
Yeah, which is considered young for a woman. We tend to have our heart attacks a little bit later than men do. So if you're wondering about family history, because that was one of the many questions that I was asked in CCU, do you have a family history of heart disease? Meaning, do you have a mother or a sister who had a heart event under the age of 65, or do you have a brother or a dad who had their cardiac event under age 55, because men tend to have theirs earlier. I had no family history. I didn't have the standard risk factors, but I did have a pregnancy complication, which we now know is significantly linked to subsequent heart attack. And that was preeclampsia during my first pregnancy.
Oh, okay.
So We didn't know that at the time. And nobody warned me when I was in the hospital with preeclampsia. Oh, by the way, you're now considered at high risk for heart disease. Never even gave it a moment's thought. We now know that a woman's risk of having a heart attack, if she has had a pregnancy complication, like preeclampsia, gestational diabetes, preemie babies, a premature baby, or a full-term low birth weight baby, so under 5 pounds, but full-term. That's a sign. OBGYNs call pregnancy the ultimate cardiac stress test.
That makes sense.
Yeah.
And so you did not have any other than the pregnancy complications, you did not have any other chronic illness or significant medical history. Would you say that your lifestyle was fairly healthy? Your diet was?
Except that I hate vegetables.
Oh, okay.
So this was my, at the hospital, they give you a little brochure about heart healthy eating. And we eat, more fruits and vegetables, and eat fish 2 times a week. And so it was very rigid. So when my daughter arrived, she was in charge of my kitchen. But she really went through my whole kitchen. She had my list and my brochure. She threw out everything that was high salt, high fat, or bad fat. Not because we know that some fats are good for us, like olive oil, fatty fish like salmon, for example. So I think I fine-tuned my diet because my daughter was such a taskmaster as soon as she got home in terms of telling me how I was going to run my life from now on. And it was because she'd been so worried and so scared at what had happened to her mom.
Tell me a little bit about the process of coming home now as a different person. You are now a person with heart disease. I assume you had new medications and processing now who you are and how to live with this. How was that for you emotionally? Did you feel you had the right supports, or did you feel you were kind of sent home and had to figure this out on your own?
That's such a good question, and such an important question, because essentially, other than the brochures that they give you about heart healthy eating, I was told to see my family doctor in, I think, 3 or 4 weeks. So I made an appointment with my family doctor. That was the extent of my discharge planning. So until that time, I just sort of limped along, and also there was a steady stream of visitors. I really don't recommend this, but that's what you do, right? You hear somebody is sick or at home or has just been let out of hospital. So you say, oh, well, we'll drop over with a casserole or whatever. So when my son arrived a couple of weeks afterwards, he was sort of standing guard because he could see how tiring it was for me to have these visitors. It's good to check with the family, I think, first, if they're standing on guard like my grown children were. But from the hospital's perspective, what I would have expected now, looking back, was a written discharge plan.
Yeah.
That lets me know, here's what might happen to you. Here's some side effects here's your list of medications, none of which I was familiar with. Even in emergency, a nurse came over to me after the diagnosis, and they were waiting for a porter to take me upstairs. And she gave me a pill, and she said, take this pill. And I said, what is that? She said, it's Plavix. I'd never heard of Plavix. I said, what is Plavix? And she said, it's an antiplatelet drug. Well, I am green as grass. I know nothing about cardiac meds. Yeah. And she's giving me a drug with a name that I don't know. And I don't even know what an antiplatelet drug is. And why am I having to take this drug right now? I wasn't even taking vitamins at that stage. So it went from 0 to 60.
Yeah.
So I had no explanation before leaving the hospital about the drugs, for example. And I had no idea how much my drugs were going to cost me. And we don't have a national drug payment policy in Canada, as you know. So it was a pretty big shock for me to suddenly have to go to the drugstore on my way home from the hospital to get this whack of drugs that I had no idea what they were for.
Did you ever at any point during this story have a consult or speak with a pharmacist during this event, or not at the hospital or anything?
And I'm really glad you bring that up, because that's what I now tell my audiences. And that's what should have been on the hospital discharge form.
Yes.
These are here's a list of your new meds. Here are the little papers that are attached with side effects. Contact your local pharmacist to discuss these for you, because you also need to know, what are they if I was taking any other drugs, would they be interacting with that? Are there certain foods that I have to avoid if I'm taking this new drug? So those are all the questions. But I was so overwhelmed, I didn't even have any questions. Like, I just did what I was supposed to do. I think in those early days, I was so overwhelmed that it didn't even occur to me to take a stroll down to my local pharmacy and have a chat with the pharmacist. It didn't even occur to me. But had that been on the list, like phone your local pharmacist and ask for an appointment to come in and have a little, meds review or something with the pharmacist, that would have been so helpful.
Mm-hmm. Or nowadays, even a virtual consult, right? That would be so nice for patients who are just discharged. And a lot of times I know that patients will come in just being discharged, or their family members, and they really cannot absorb too much information. We have so much information to tell them, and really a follow-up in maybe 4 or 5 days once they're settled in, as long as they've got their medication, is probably more effective and will be received better than even that initial, you're just trying to get yourself home, right?
Exactly. That's very true.
So you're at home, and your son and your daughter are there, and they are taking care of you and trying to ward off too many visitors. How are you doing emotionally at this point?
One, I could see how worried my family were all around me. Like, not only my immediate family, but all my Ontario relatives and my neighbors and my coworkers at the hospital. I could see that they were worried, and especially my children. I never want to see that look on my kids' face ever. We're the moms and we take care of our kids, even if our kids are grown. And so I tried, when they were around, when we were interacting, like at meal times, for example, when I wasn't napping, because I remember I napped a lot in those days. But when we were interacting, I tried to put on a happy face and be fine, because I knew that's what they needed. They wanted mom to be fine. And they would look at me every morning and say, "How are you doing?" And I remember the first time I had to take nitro after I had been discharged from the hospital. And the nitro was the only thing I remember that they said, if you have chest pain, take nitro. They didn't tell me how to take nitro. And there's a really good system that I wish nurses and doctors would tell patients. If you have a spray, for example, and it's very simple. It just involves sitting down. Nobody told me you have to sit down. And the reason for that is sometimes nitroglycerin can make you feel lightheaded and you might fall down. So it's a good idea to sit. And this is very common in newly diagnosed patients, where every twinge you think, "Oh my goodness, is this something? Is it nothing? Should I call 911? Is this the day I have to go back into the hospital?" That is a pervasive fear among recently diagnosed heart patients. So taking nitro, the first time my daughter was with me, so she's like staring at me like, I'm an animal in a zoo, and she's watching everything I'm doing, and I don't know what I'm doing because it's the first time I'm taking it. I think you put it under your tongue. I'm not sure. Like, the directions were not really clear. The directions are for somebody who's calm and who's, mentally functioning. And that wasn't me. So I just tried to do the best I could. And sure enough, in about 5 or 10 minutes, the chest pain seemed to ease up. So I thought, oh, that's good. Because I learned that if it doesn't ease up, you wait 5 minutes and you take another dose of nitro. Nitro, as you know, is a vasodilator, helps to open up the blocked coronary arteries. And if the second dose doesn't work, you can take a third dose, but you better be calling 911 at the same time. So even taking the first dose is frightening for a heart patient, because you know what's coming. You've left the hospital where for 24/7, you have been surrounded by nurses and doctors and dietitians and all kinds of hospital staff whose only job is to make sure that you're fine and that you're stable and that you're ready to safely go home. And so then you wave them goodbye, and suddenly you walk home, you go into your house and you know nothing. It's kind of like, I compared it to the first day you bring your baby home from the hospital.
I was just thinking about this. Yes.
So here's an example that I learned years later of something that's extremely common: stretch pain. I'd never heard of this, but I experienced a lot of this stretch pain. It felt just like having a heart attack. And it's just the reaction of the coronary arteries to being stretched with especially if you have balloon angioplasty, they blow up this balloon.
Yep.
And it's quite a shear force. So it can hurt afterwards, just as you would in any other body part that had something sudden done to it.
Mm-hmm.
So because this is a very sensitive part of the body, it's very common, except doctors don't warn you about this before you go home from the hospital. So that when you start having chest pain, you start panicking, you start thinking, is this something? Is it nothing? Should I call 911? I'm pretty sure that a lot of emergency visits after heart attack are because people have undiagnosed post-stent chest pain, which is usually very benign. It heals up on its own, usually within the first few weeks, sometimes a couple months, you'll be back to normal. But if you don't know this at the time, it causes a lot of anxiety. It's like post-heart attack depression, very common. They call it situational depression. Something, life-altering has just happened to you and you're supposed to bounce back, but you don't really have the ability to bounce back because you're not feeling well. They say that some doctors think that if you mention this, that, oh, by the way, post-heart attack situational depression, treatable, temporary, benign, but it might worry you if you have never experienced this before. Some doctors have told me that they think if they say that out loud to a patient, they'll just go home and become depressed because it's really insulting when you think about it. We better not tell these patients about the possible side effects because then they'll just, develop these, they'll turn into hypochondriacs, as opposed to this would be reassuring. Had I known, days where I couldn't stop crying, for example, or I couldn't get out of bed in the morning. I remember I had a doctor's appointment one morning and I was thinking really hard. I was sitting on the bed thinking about whether or not I should wash my hair so that I would look good for the doctor. And that I was I had to think about this as opposed to getting up in the morning and going to take a shower, which is my old life. But I realized I couldn't remember when the last time I had a shower was. It could have been 4 days or 2 days. I couldn't remember. And should I take one today? That's the level of non-function that I was experiencing. And that's pretty scary when all your life you've been a pretty functional person. And then suddenly you think, what is wrong with me? What is going on? Honestly, I thought I was losing my mind.
And that's why this story is so important, because there are so many things we're not told after we have any kind of medical event, even. It's not just, say, a heart attack. And so knowing that it's not just what happened to you physically, you take that home with you, your body is processing all of this, and there are psychological consequences as your mind processes what just happened to me and how do I live now knowing this is who I am now, right?
It's so true. And suddenly you're all alone at home and feeling these very unusual feelings that you are not familiar with. Until that point, I'm embarrassed to say how I used to talk about depressed people, like these people who would take stress leave. And I'd think, oh, please just pull your socks up and get on with it and stop feeling, this little pity party. So I was really mean because I'd never had a depressive moment in my whole life, apparently, until after my heart attack. But of course, that's going to affect you. And so if your doctor says, okay, you've had a heart attack, so here's what you're going to do. Here's what's important. You have to stop smoking. You have to start eating a heart healthy diet. You have to start exercising every day, and you have to get a good night's sleep. So, we're going to order a sleep test, and you probably will have to use a CPAP machine at night, and all this long list of things that you have to do. Oh yeah. And you have to take this fistful of drugs every day, brand new drugs. That person who has a list, I have a to-do list from my doctor or from the brochure or from somewhere about what I should be doing to live a heart healthy life. Except that if I'm so depressed, I cannot get out of bed in the morning, I can't stop crying, that's not going to happen. And that means that we'll become non-compliant patients. That's what doctors call us when we don't do everything that they tell us that we should do. When the real culprit here was this post-heart attack depression.
So what did you do from that point to kind of put your life back together, and what kind of help did you
Well, the best thing I did, I have to say, is there's a class in that's run out of the Jubilee Hospital, but it's called Heart to Heart, and it's a 7-week educational program for new heart patients.
Okay.
And it was started here in Victoria by a nurse whose dad had been released from hospital and was just totally overwhelmed after his heart attack, didn't know anything. He was like me, right? He didn't know anything about what he should do or shouldn't be doing, what had happened to him, what the pills were for. Because she was a nurse and she was a go-getter, she started, lobbying that what we need is to have some little classes, and we bring in guest speakers, and that's what Heart to Heart did. On the first week, they bring a cardiologist in for 2 hours to explain what has happened to you. And this covers all kinds of heart events, not just heart attacks, but heart arrhythmias, valve problems, open heart surgery, all kinds of cardiac events, as they call them. And then the pharmacist comes in this next week, and then the dietitian comes in, and the social worker comes in to talk about mental health issues. So by the end of 7 weeks, that was a lifesaver for me.
And this experience for you has been so significant. You've actually written a book about...
I have, but the book is based on my blog, Heart Sisters. And I started writing Heart Sisters because the other amazing, wonderful thing that happened was 5 months after my heart attack, I applied for and was accepted to attend an annual training program at Mayo. It's all expenses paid. The program is called the Science and Leadership Training for Women with Heart Disease. And they train women like me, about 40 women a year. And it's like cardiology boot camp.
Wow.
And you go home after 5 days and you do what I'm doing now. I'm talking to other women about heart disease. And it's been so successful that it just keeps happening every year. So I learned a ton because of my Mayo training. And after Mayo training, I was already thinking, how can I tell other women what I've just learned at the Mayo Women's Heart Clinic? And I started this little blog, a little stationary 3-page blog about how to book a talk. That's basically, because I was spending a lot of time on the phone with women who were had been to one of my talks and wanted to book their own talk or wanted me to speak to their Rotary Club. So this was becoming like a little part-time job for me. So I thought, I'll just do a little blog. And before you knew it, my blog had grown and grown. I think we're up to 900 articles so far. And Johns Hopkins University Press down in Baltimore was familiar with my blog. And they sent me an email one day and they said, "We love your blog. We love how you write. Would you consider writing a book based on your Heart Sisters blog articles with us?" So I thought about it for a while. And then I said no, because I'm a heart patient with ongoing cardiac issues due to what they call microvascular disease, diagnosed a few months after my heart attack. So I got 2 diagnoses for the price of 1.
Wow.
And these are the it's sometimes called small vessel disease. So not the big vessel where my heart attack started, but as the large blood vessel branches out and gets smaller and smaller, these are this small microvascular vessels, too small to stent, too small to bypass, but still cutting off blood flow to the heart muscle. Put it this way, she said, "You've already written the book. You've got 900 articles, or 700 in those days. You just take a couple paragraphs from this article and a couple paragraphs from that article, and you just put them together, and there's your chapter. And then you do that 10 times, and you've got a book." And I thought, oh, that sounds easy. So I said yes. And 2 years later, we had the book. Yeah. And the book is called, hang on, let me see if I have a copy here. The book is A Woman's Guide to Living with Heart Disease.
And I just love when a tragic story turns into something that can actually help other people. And we'll leave links to the book and your incredible blog on the video here, and go and visit the blog page. It is a wealth of information, more information you could ever imagine, but very easy to read and very, very practical. So I totally understand why Johns Hopkins would have reached out to you, because it's very, very good quality information. And how are you today, Carolyn?
I still have microvascular symptoms every day. So about 4 days a week, I judge how things are going by how much nitro I consume. Nitro is your friend. Nitroglycerin is one of the oldest medications that's available. It's cheap. It's very effective. There are virtually no side effects except for the famous nitro headache, which you can kind of avoid if you take Tylenol, just, 10 minutes or so before taking it. So over the years, it's just become normal. It's amazing. I often think that the level of chest pain that I live with, which is normal now, I'm just used to it. And this is so true of people who live with chronic pain. Chronic pain people do not bunk out at emergency, even though they're in terrible terror. They have the kind of pain that would send most people rushing to emergency. And I think that's true I have what's called refractory angina. So that's angina that does not respond to normal medications or treatments that work for most people. So I've had to learn how to self-manage, and I've had lots of help with it through the Self-Management BC, which is a wonderful free program. Again, this goes back to patient education.
Yeah.
And they do fantastic classes in pain self-management and chronic illness self-management, again, because we're the ones who are doing the work.
Mm-hmm. And Carolyn, what would you say to if you knew that you were going to have a heart attack that 2 weeks before, what kind of advice would you give that Carolyn today, or other women who are listening to this and may next week start to have some of these symptoms?
Yeah, that's such an important question. And I think that it boils down to it's almost a societal shift as well as an individual shift. We have to start looking at ourselves as the top priority in our life. And for women, this is difficult for many women. Mayo Clinic did a survey on women's priorities that I learned about when I was at Mayo Clinic. And they asked women, what is the most important thing on your priority list? Because they were concerned that even in the middle of a heart attack, women like me, I was having these severe symptoms, but I didn't want to go back to emergency. I didn't want to embarrass myself again by making a fuss. And not making a fuss is huge for women. So in this survey, the women's answers, though, were pretty well how I would have answered my own priority quiz. Number 1, family. Number 2, home. Number 3, work. Number 4, pets. Number 5, spouse, right under the dog.
Pets before spouse.
Yes. And the last on the list is myself. You. Even when we're experiencing heart attack symptoms, in mid-heart attack, we know that women are less likely to seek immediate attention. We take much longer between the onset of symptoms and that first step to seek emergency help than men do. And there was a study out of England several years ago that said men have much better outcomes after a heart attack compared to women. And I looked at the study and I thought, well, duh, it's because a lot of those men have wives. And right. As soon as the husband says, oh, I feel horrible, I'm feeling this, and she says, that's it, we're calling 911, off we go. Whereas women will argue with their spouses. And there's these researchers who study treatment-seeking delay behavior tell us this, that women tend to minimize our symptoms. We'll only seek treatment if somebody is with us and we say, oh my goodness, I'm feeling this or that. And our girlfriend or our sister or somebody says, we're calling 911, then we'll go along with them, but we won't do it on our own. And it takes a lot of convincing women to drop what we're doing and to make ourselves as important. So the question I ask at the end of my talks is always the same. What do you think I would have done had it been my daughter, Larissa, or my sister or my mom experiencing all of those symptoms for that whole on the plane and at my mom's birthday and at work every day? What do you think I would have said had it been a woman that I love rather than me? Well, the answers are all unanimous, and they all say you would have been screaming blue murder to get help for your mom or your sister or your friend or even a perfect stranger. If I was on the plane next to a stranger who was having serious symptoms, I would be demanding that they turn the plane around. But I didn't do that for myself because I was too embarrassed about making a fuss. So I warn my audiences now, don't be embarrassed to death, because that's often the alternative when you're talking about heart attacks.
Mm-hmm. And it is so true that we just don't, we even see the strain that the healthcare system is under, and we don't want to be part of, another nuisance in the emergency room, right? And so not seeking the care when we need it is something that concerns me more and more as we see the state of healthcare right now.
Yes,
and Carolyn, time is very important, right?
Oh, time is muscle.
Our heart muscle goes,
Doctors
right?
like to say time is muscle. Yeah.
Do you feel like you have adequate support today to deal with your heart condition?
I do, but like many people living with a chronic and progressive condition, self-management is why I'm doing as well as I've done. And it's been years. I had my cardiac event in 2008. Both the heart attack and the microvascular disease diagnosis both happened within 6 months of each other. So very quickly, I had to get up to speed in terms of what can I do? How am I going to live my life day to day? I was unable to return to work, for example. This was a huge stressor. I had a return to work trial at the hospital, half days only to start, but I knew within a week that I could not, I knew, and worse, my colleagues and my boss knew. Everybody could tell that I was no longer to function in the capacity that I used to function because of these ongoing symptoms that I was pasting my little happy face on every day, insisting that I'm fine, because I wanted to be normal again. I wanted life to be normal. I really thought if I could only get back to work, then I would feel normal again. Well, what I was really saying was, if only I didn't have this cardiac condition, I might feel like my old self. And the reality is that I've had to, learn along the way. So now I'm getting pretty good at coping, just like all people with chronic illness get amazingly. They may not be happy about it, but when you consider the alternative, which is to be parked out in front of emergency every day, which is not going to happen, or at their doctor's office every day, which is also, it should not be happening. There's a lot about the self-management that I've had to learn on my own. And that's really, so it isn't that I'm getting support on a day-to-day basis now. Support's very, very important for what I call the freshly diagnosed. That's when those people are like sponges. They ask lots of questions. Everything is new to them. Everything is scary. So it can be very helpful to have either an in-person support group, an online support group. There's an excellent one called from WomenHeart. That's all one word. That's the National Coalition for Women with Heart Disease. It's based out of the States, but they have an excellent online support group with 40,000 plus women living with heart disease from all over the world. Does anybody else have this problem? And then the next morning you'll wake up and there'll be, answers to your questions. So it's very comforting to the freshly diagnosed.
Mm-hmm. And you touched on an important point that there are so many people who suffer from chronic illness, and it's largely invisible to the public. Mm-hmm. And these people are coping with pain, like you said, chronic pain, fatigue, a lot of different symptoms daily. And we do try to, put on a good face for everyone. But self-management is so important. Can you tell us a little bit of what that looks like for someone who really doesn't know, doesn't see? What we see right now is we see a lovely, healthy woman telling us a tragic story, right? We can't see your illness right now, right?
Well, here's a story that I heard during one of the classes that I took on pain self-management, that when you go to, let's say you have a headache and you go to your medicine cabinet to get your pain medication, because you know that whenever I have a headache, this will work. You put the pill into your mouth and you take a drink of water, and immediately studies have shown that people start reporting relief within minutes. As soon as you take your pill, you know that it will start working and your headache will be better. And yet our nervous system says, aha, now we have relief. And just the opposite is true. If you have your headache, you go to the medicine cabinet, you take out your bottle of pain medication, but it's empty. Right away, your headache will now be right off the Richter scale. Nothing has changed. Nothing has changed to make that headache worse, except your nervous system telling you, warning, 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 you're out of pain meds, and now you're on your own and the pain's going to be horrible. And sure enough, the pain will be horrible. Now, it isn't that the pain doesn't exist, it's that we have tricked our nervous system. So much of pain self-management is tricking our nervous system, because right now we know that any pain, especially if it's a bad pain that we've had before, we tend to immediately say, uh-oh, here it comes again, it's going to be horrible. And we're totally geared up to translate even a touch, something that we know is not hurting any body part, but even a simple touch will feel like agony, because that's what our nervous system has tricked us to believe. So there's some really interesting, I'm very interested in pain management research. And it's not pain control, it's pain management. Like I said, most people would go to emergency if they had the kind of pain that I have, but I've learned to tell the difference between pain that's really different, really serious, very unusual for me, and just kind of normal garden variety pain that people who live with chronic pain learn to live with.
It's such an incredible story and an incredible journey that you have been on. Just before we go here, could you just touch on, I know that your symptoms of heart attack were very, what we call typical. However, a lot of women do not have these typical symptoms. Right? There are other symptoms that some women just report feeling really unwell for, right?
Yes. Women feel, Dr. Sharon Hayes, who's the founder of the Mayo Women's Heart Clinic, has a great line about telling the difference between men's heart attack symptoms and women's heart attack symptoms because of this emphasis on atypical symptoms. She said it's less important to look at differences than to identify this is a heart attack, no matter what the symptom is. So I have met women with bizarre heart attack symptoms, a persistent cough. At Mayo, they tell us that anything between neck and navel that comes on with exertion and tends to go away with rest should be identified as cardiac until proven otherwise. So this includes shoulders, neck, jaw, right or left, right arm or left arm. Some research says that there's likely more likelihood of damage to the heart muscle if it's the right arm that has the symptom. Oh. So either arm, elbows is often reported by women, or a feeling like your bra is too tight. This is a very common symptom often expressed by women. That, like, I met a woman once who had to stop the car driving home and take her bra off in the car because it was so unbearable. Now that's not normal for her. So anything that's not normal, it may be normal for other people, but if it's never happened to you, and if you don't know what's happening, that's the symptom that you should be looking at. And also the advice is when you do go to emergency or to your family doctor to mention it, don't diagnose yourself by saying it's probably nothing. Don't apologize for being a bother. And don't offer alternative diagnoses. Gardening yesterday, so I think I must have pulled a muscle in my chest. Just shut up. Say, I think I'm having a heart attack. And men do this all the time. Men will go in. There's a whole field of research on linguistics, actually, about how women speak to emergency room staff. This is a real small focus of research, but it's my favorite subject. There's a Canadian researcher, Dr. Catherine Kriatsoulis. She's a Canadian, but she's at Harvard studying this very thing. How do women talk to emergency doctors? And does this have anything to do with the fact that women are far more likely to be misdiagnosed in mid-heart attack compared to men? So she has found that women talk more. We just tend to we're storytellers, whereas men will go in and say, oh, I think I'm having a heart attack. And then they're very short on words. They're busy having their heart attack. Whereas women will say, well, it all started yesterday, then it got a little bit better. And I was gardening, so that's what I was thinking. It's probably a pulled muscle. Or I was very stressed yesterday, and that's probably what it is. Like, so as soon as you find yourself going into storyland, stop talking and just say, I think I'm having a heart attack. And if they say, I think it's acid reflux, because you're in the right demographic for acid reflux. So don't make it harder for your doctor to appropriately diagnose you. Say, I think I'm having a heart attack. And if the doctor says, something that you think, no, I don't think it's that, say, I know my body. I know when something is wrong with me, and this is something very different for me. So this is especially important if you've ever been diagnosed in the past. Like the doctor said, have you ever had acid reflux before? If I had said yes, he wouldn't have probably have ordered any cardiac tests, because he would have immediately, it's the most likely thing is that this is another episode of acid reflux or anxiety or something else that the patient's already mentioned.
That's so important. And these tests are not that complicated. To do some simple screening tests when someone goes in, some simple blood work, put you on a heart monitor for a minute or so, that gives them a lot of information to go with. So it's not like you're asking for the world when you go in and you say this.
Yes. The thing is that a lot of times the person who goes into emergency, first of all, most of us are not used to being in emergency. Emergency is a very scary place.
Yeah.
We're not feeling well. We're overwhelmed and confused. And we're also very frightened that this might be a heart attack. So often, like, I can make a decision sitting here in my kitchen that's very different than the decision I might make while I'm in the middle of a frickety frackin' heart attack. Mm-hmm. So that's why I was making all those bad decisions on the plane, like not getting off the plane in Vancouver, for example, or not getting on the plane in Ottawa. So the patient is often the least likely person in the room to be able to be thinking clearly and to be making sound decisions. So you have to override that part of yourself that says, oh, it's probably nothing. Or if it's still bothering me tomorrow, maybe I'll go. Or as soon as I finish this project, or dropping the kids off at skating, or whatever excuse because denial is very common. It's common in men and in women. Science of denial, where people think, really interesting, a police study where armed bank robbers were seen fleeing the building with guns. And even the security guards on duty thought, oh, maybe they're filming a movie. So denial is part of everyday life, that what's bad, that if it's raining, it'll probably stop raining. It's not raining as much as we thought it was. So denial during a heart attack is especially pervasive, because that's a terribly scary concept. And that's another reason that I believed the doctor. When he said acid reflux, I thought, okay, great. I'd much rather have indigestion than heart attack. Thank you very much. So I was happy to be misdiagnosed, which sounds crazy, but so you have to override that sense of denial and that sense of not wanting to make a fuss.
Yeah, and this is so important that we get this information now before an event or something, so we know how to advocate for ourselves when the time comes. Because when you are in that position and you do not have this education, you do not have someone saying, I heard Carolyn say that I should say, I think I'm having a heart attack. If you just go in there, you can easily be misdiagnosed, like you said. So knowing that you have to advocate for yourself, express what your symptoms are, say what you think this is, and leave it. And, hopefully you will get the right treatment.
Yes. There's one more symptom that I wanted to mention, because it's very common in women, and that is a heart attack symptom specifically, that is a sense of impending doom. So often after the fact, women will report, they may not say that to the emergency doc and the hospital, but afterwards they'll say, I knew it. I had this horrible, icy feeling that something horrible was happening. And if you've never had that feeling before, and now you have it, that turns out that's linked with cardiac diagnoses down the road, that almost all heart attack patients will report after the fact. Or often they'll say, that's what sent me to call 911. It wasn't the chest pain. It wasn't these other symptoms. It was this overwhelming, overpowering sense that I'd never had before. That and crushing fatigue. I wanted to mention this because often, if a woman goes to her doctor and says, I'm so tired, I don't know what's wrong with me. We're all tired. What woman is not tired, right?
Yes.
So, but you have to communicate the symptom in a way that the doctor will pay attention to it. So I recommend that you describe function rather than just, I'm so tired. So for example, no longer carry my laundry basket. So that's not being able to carry a laundry basket is a simple and yet very picturesque way of saying, whoa, that's not normal. Mm-hmm. That you can't carry a little laundry basket anymore, as opposed to, I'm so tired. I don't know why. I'm just always so tired. So learning how to communicate your symptoms effectively in a way that will get the doctor's attention is really helpful.
Carolyn, so what keeps you busy these days? What are you up to? How's your quality of life, Carolyn?
Well, my general quality of life these days, especially with COVID, is vastly improved because I have a new little grandbaby. Oh, so spending time with babies, I highly recommend it. They say if I'd known how fantastic grandbabies were, I would have had them first.
Yes.
Yeah, so my mornings especially, I tend to be really perky in the morning, and then I fade as the day goes by. So I've learned to schedule things like my chat with you this morning and early in the day when my brain is semi-functional.
Yeah, and that's that self-management piece that you were talking about as well, right? Carolyn, thank you so much. You are a wealth of information. You have your own personal story, but also you just provided us with some incredible education about how to advocate for our health, in particular, if we have any signs or symptoms of a heart attack, how to seek help soon, and how to be clear in our communication with the medical professionals. So thank you for your time. Again, I'll put links to your book and your blog in the description of this video. And it's been a real pleasure. Thank you so much for joining us today and sharing your knowledge.
You're welcome. It was lovely chatting with you.
The leading cause of death in women is heart disease. This is greater than all respiratory diseases and cancers combined. My hope is that this story will cause you to be able to recognize better these signs and symptoms of a heart attack, that you will be able to advocate for yourself better if you do experience these symptoms. Please do share this video with friends and family members. You could be saving a life, and you could be saving someone's heart. Thank you so much for joining me. Take care and stay healthy. Bye-bye.